What if I told you that the cure to, like, one of the most painful but totally unspoken side effects of menopause was, well, fish sperm?
I mean, when you say it like that, it sounds completely absurd.
Right. Okay, let's unpack this, because it honestly sounds like, I don't know, a rejected plotline from a sci-fi novel, but it's actually a very real, very cutting-edge medical reality.
Yeah, it really is.
And we have a highly specific mission for you today on this deep dive. We are asking, are polynucleotides, which, yes, are literally derived from trout and salmon DNA, are they a safe alternative to hormone replacement therapy for intimate health?
And to actually answer that for you, we've pulled together a pretty comprehensive stack of source material today. We're synthesizing the latest clinical guidelines from the British Menopause Society, the National Institute for Health and Care Excellence, or NICE, the American Urological Association.
Which is a lot of heavy-hitting data.
Right, it's a lot. And we're also digging deep into the clinical trial data. Specifically, there's this pivotal 2019 Palmieri exploratory study, and we're looking at that alongside the actual treatment protocols that specialized women's health clinics are using right now.
Awesome. But, before we get into the actual mechanics of injecting fish DNA, which we will definitely get to, we have to look at the massive void that this treatment is even attempting to fill.
Yeah, the underlying issue.
Exactly. We were talking about Genitourinary Syndrome of Menopause, or GSM.
Mm.
And according to the American Urological Association, this affects up to 80% of all women following menopause.
It's just a staggering prevalence when you think about it. I mean, the genitourinary tract relies super heavily on estrogen to just maintain its thickness, its elasticity, and, its natural lubrication.
Right, needs that fuel.
Exactly. So when that estrogen drops, the tissue fundamentally changes. I mean, it literally thins out. The pH level in the vagina rises, which then alters the bacterial flora, and that ends up inviting things like recurrent urinary tract infections.
Which are awful.
Yeah, and it leads to severe dryness, burning, and dyspareunia, which is the medical term for painful intercourse.
And what's wild to me is that the British Menopause Society labels GSM a silent epidemic, which, honestly, that feels like a total contradiction.
How so?
Well, if 8 out of 10 women are experiencing something this physically disruptive, like, why is it silent? I mean, if 80% of the population suddenly felt like they were walking on broken glass every day, it would be front page news every single day.
Oh, absolutely. But the silence is, well, it's multi-layered. Obviously, there's a lot of societal stigma surrounding women's intimate health in general.
Sure, nobody wants to talk about it.
Right. But beyond that, there is a very specific clinical reason for the silence. The British Menopause Society points out that the symptoms of GSM are notoriously delayed.
Delayed, like they don't happen right away.
Exactly. Think about hot flashes and night sweats. Those usually happen right around the initial menopausal transition. So women immediately associate those symptoms with the underlying cause, which is menopause.
Cause and effect. It makes sense.
Right. But GSM symptoms often don't become really severe until 3, 5, or sometimes even 7 years post-menopause.
Wow, 7 years later. So it's kind of like it's like a check engine light that comes on 3 years after you bought the car.
That's a perfect way to look at it, yeah.
Because the warning light took so long to actually activate, you just don't immediately connect it to the core engine issue, the drop in estrogen. You probably just assume it's normal wear and tear.
Yeah, you just think, well, it's an inevitable part of getting older.
And so women just suffer in silence, thinking nothing can be done. That is heartbreaking.
It really is. They completely lose the association. Now, for many women, the standard first-line treatment for this is pretty straightforward and highly logical. It's local estrogen therapy.
Okay, so just putting the estrogen back.
Exactly. You apply a localized cream or maybe use a vaginal pessary or a ring. Basically, you are putting the missing hormone right back into the exact tissue that needs it, which restores the blood flow and gets the cells to mature properly again.
Which sounds great, but our whole mission for this deep dive is about finding an alternative. Yeah. And that kind of implies there's a problem with that gold standard.
Well, the problem is what we call the HRT gap.
The HRT gap. Okay, what is that?
So local estrogen is incredibly safe and effective for the vast majority of people. But for a really critical subset of the population, it is strictly off the table.
Because of cancer risks.
Yes, exactly. The most vulnerable group caught in this gap are women with a history of estrogen-dependent breast cancer. And specifically, we're talking about women who are on maintenance medications called aromatase inhibitors.
Oh, right. Those are the drugs that are basically designed to starve the body of any residual estrogen. Right.
Spot on. They block the specific enzyme that converts androgens into estrogen. So for a woman on an aromatase inhibitor, her systemic estrogen levels are effectively suppressed to zero.
Just to prevent the cancer from coming back.
Exactly. So for her, introducing even a localized vaginal estrogen cream is fraught with anxiety. It requires this really complex, highly cautious, shared decision-making process with her oncology team.
Because there's a chance it could get into the bloodstream.
Right. There is always, a theoretical risk of systemic absorption.
Man, that is tough. I mean, you're asking a woman who has literally battled breast cancer to apply a hormone that her body is actively trying to suppress.
It's a huge mental hurdle.
Yeah, even if the systemic risk is, like, microscopic, the psychological burden of opening that tube of estrogen cream every single night has to be immense.
It's incredibly heavy.
But okay, if estrogen is completely off the table for them, what about the other options? Because the sources did mention oral medications like ospemifene or vaginal inserts like prasterone.
Yeah, so ospemifene is what's called a selective estrogen receptor modulator, or a SERM. It isn't technically estrogen, but it binds to the estrogen receptors in the vaginal tissue to mimic its effects.
Okay, and the other one?
Prasterone is a vaginal DHEA insert, and that is an inactive precursor that the local cells actually transform into intracellular estrogen.
Wait, so they are still pulling the exact same biological levers?
Basically, yes.
They're still totally operating on hormonal pathways?
Exactly. And if we connect this to the bigger picture, we have millions of women with symptoms so severe, they describe intimacy as feeling like sandpaper or razor blades.
Which sounds agonizing.
It is. And we have these great hormonal treatments, but we also have this massive population who either absolutely cannot take hormones due to cancer or who simply prefer a completely hormone-free approach.
Right. And so if you can't use hormones, and you really can't use things that even mimic hormones, what biological lever is even left to pull? Like, how do you fix a highly atrophic tissue without touching the endocrine system at all?
Well, that is the million-dollar question. And the answer is you go straight to the DNA.
Which brings us back to the fish.
Enter polynucleotides, or PNs.
Yes, and we have to address the elephant, or I guess the trout in the room.
I knew this was coming.
I mean, I have to ask, why on earth are we using DNA derived from fish sperm?
Look, it sounds completely bizarre until you actually look at the biology of a sperm cell.
Yeah.
A sperm cell is essentially just a microscopic delivery vehicle.
Okay, go on.
It doesn't have all the complex organelles and, cellular machinery that a liver cell or a muscle cell has. It is simply a densely packed, highly concentrated payload of pure DNA.
Oh, I see.
Yeah. So if you want to extract a massive amount of nucleic acids really efficiently, gonads are just the best source.
Okay, that actually makes biological sense. But why salmon and trout specifically? Why not, like, cow DNA or something?
That comes down to safety. Salmonids are cold water fish. So when their DNA is extracted and highly purified for medical use, it is structurally very similar to human DNA.
Interesting.
But because it's from a completely different class of animal, there's virtually no risk of transmitting mammalian diseases.
Oh, that is super smart.
Yeah. Furthermore, the purification process strips away all the proteins that would typically trigger, an allergic or immune response. So what you are left with are pure polynucleotides.
Which are what, exactly?
They are basically bioactive chains of nucleotides, which are the fundamental building blocks of life.
Okay, so we have this highly purified fish DNA, but how does injecting that actually heal the vaginal tissue if it isn't acting like a hormone?
It requires a totally different mindset.
Right, because, okay, think about HRT, like hiring outside contractors to constantly ship in building materials to a failing factory.
That's a great analogy.
Thanks. Like, you have to keep paying the contractors, basically applying the estrogen every single day just to keep the factory running.
Exact.
But polynucleotides seem entirely different. They aren't bringing in outside building materials, are they?
No, not at all.
They are acting more like a new management blueprint that gets handed directly to the local factory workers, basically telling them to start manufacturing their own materials again.
That is a much more accurate way to look at the mechanism, actually. Polynucleotides do not bind to estrogen receptors, period.
Okay, so what do?
When they are injected into the vulvovaginal area, they initiate a process called biostimulation. They send a targeted signal directly to the fibroblasts.
Ah, The local factory workers.
Exactly. Fibroblasts are the cells responsible for producing collagen, elastin, and the extracellular matrix.
And that matrix is like the structural gel that keeps our tissues plump and hydrated, right?
You got it. Now, in a postmenopausal woman, those fibroblasts have basically gone dormant because the estrogen that used to stimulate them is just gone.
They're laid off.
Right. But when you inject polynucleotides, enzymes in the tissue slowly break down these DNA chains into individual nucleotides. And the fibroblasts basically feast on these raw materials.
Oh, wow.
Yeah, they use them as both energy and the literal building blocks to synthesize brand new collagen.
So it's not a temporary Band-Aid at all? You are fundamentally rebooting the tissue's own localized cellular machinery.
Precisely. And the clinics are using very specific formulations for this now to make it even more effective.
Right. The source is highlighted an injectable treatment called Nugen, I think, which blends these polynucleotides with hyaluronic acid and sugar alcohol called mannitol.
Yes, and that combination is highly intentional.
Why add the other stuff?
Because the polynucleotides take time to stimulate the fibroblasts. It's a biological process, so it takes weeks. But the hyaluronic acid provides immediate structural support, and it draws massive amounts of moisture into the tissue right away.
Okay, instant relief.
Oh.
And the mannitol.
The mannitol acts as an antioxidant. It basically protects the hyaluronic acid from breaking down too quickly in the body.
Oh, that's clever.
Yeah.
So the patient gets instant relief and hydration from the hyaluronic acid, while the fish DNA does the heavy lifting in the background to physically rebuild the tissue architecture over the next few months.
Exactly. It is a complete paradigm shift. I mean, we're moving from endocrine therapy, fixing the plumbing by adding systemic hormones, to pure regenerative medicine.
But okay, theory and clever biology only get us so far, right? Does this blueprint actually work in the real world on women who are actively suffering?
That is where the clinical evidence comes in. And for that, we turn to the 2019 Palmieri exploratory study on vulvovaginal biorevitalization.
Okay, let's look at the data.
This research specifically targeted postmenopausal women who are suffering from symptomatic GSM. And these were not mild cases, to be clear.
Right.
These were women experiencing significant daily discomfort, severe dryness, and really high levels of pain during intercourse.
So what exactly did they do to them in the study? I feel like the methodology here is pretty crucial.
It is. So the protocol involved a series of what they call priming sessions.
Right. Yeah.
Think about it. If you have tissue that has been starved of estrogen and raw materials for years, you can't just give it one single injection and expect a miracle.
Right, you'd need a lot to get it going.
Exactly. You have to flood the area with these building blocks. So the researchers administered these highly concentrated polynucleotide injections at specific intervals, and they evaluated the women repeatedly up to a 90-day mark.
Okay, and what were the numbers? Did it actually work?
The results were rapid and statistically significant. After just the initial priming period, the women reported a massive drop in their symptoms.
Massive.
The clinical scores for burning, itching, and soreness fell by over 50% compared to their baseline.
Wait, really? A 50% reduction in constant itching and soreness just from the initial loading phase.
Just from the initial phase, yeah.
I mean, that alone is a massive quality of life upgrade.
And it gets better. By the end of the 90-day follow-up, the scores for dyspareunia, that severe pain during intimacy, and severe vaginal dryness, those had fallen by almost 60%.
Oh, wow. Almost 60%.
Yeah, and it wasn't just subjective symptom reporting either. The researchers noted that clinically, the polynucleotides rapidly restored the microscopic erosions and dystrophic defects in the tissue itself.
Meaning the physical micro tears in the vaginal walls were literally healing.
They were healing, yes.
Almost a 60% drop in painful intercourse without a single drop of estrogen. For an oncology patient, that is revolutionary.
It truly is life-changing for that demographic.
But, we really have to talk about the actual patient experience here, because this isn't just swallowing a pill with your morning coffee.
No, it's definitely a procedure.
Yeah, you are asking someone who already has severe pelvic pain, whose tissue is described as atrophic and easily torn, to voluntarily undergo a series of vaginal injections.
Right. It is a clinical procedure, and it does require a commitment. The standard protocol we see in the clinical data usually involves 3 to 6 sessions, typically spaced about 2 to 4 weeks apart.
Which sounds painful on its own.
Well, because the vulvovaginal area is highly sensitive, clinics do apply a strong, specialized numbing cream well before the procedure even starts.
Okay, good to know. But let's really look at the logistics of this, right? Because the sources explicitly state this is not a one-and-done permanent fix.
Right, aging is still happening.
Exactly. Time marches on.
Okay.
So after those initial 3 to 6 sessions, you need a maintenance top-up session every 6 months.
Yes, typically biannually.
So I have to play devil's advocate here. If I have to book an appointment, take time out of my busy day, sit in a waiting room, get numbing cream applied, and then undergo intimate injections twice a year, how is that practically better than just using a daily estrogen cream in the total privacy of my own bathroom?
It's a really fair question. It basically becomes a debate between the convenience of administration versus the burden of systemic risk and, honestly, mental load.
What do you mean by mental load in this context?
Well, if a woman has no contraindications and responds beautifully to a daily local estrogen cream, that might very well be her preferred route. It works. It's easy.
Right.
But a daily or even biweekly cream is a constant, relentless medical routine. It is a daily reminder of the condition itself.
Oh, I see. You can never just forget about it.
Exactly. But with the polynucleotide protocol, you undergo the biannual clinic visit, you heal for a couple days, and then you don't have to think about your condition or manage a prescription routine for another 6 whole months.
I hear that. I do. But still, injections in that highly specific area, the vulnerability of the procedure alone might turn a lot of people off, regardless of how much mental load it saves them in the long run.
And that's completely valid. But compare that vulnerability to the anxiety of a breast cancer survivor.
Okay, fair point.
Imagine holding a tube of estrogen cream, right, and you are staring at a black box warning label about cancer risks, knowing you are actively on heavy medication to suppress that exact hormone.
Yeah, that would be terrifying.
For those women, the inconvenience of a biannual clinic visit isn't a burden at all. It is an absolute lifeline.
That makes total sense when you frame it that way.
And the recovery is actually minimal. It's usually just 48 to 72 hours of mild swelling or some temporary redness. There's no surgery, no general anesthesia, no cutting. So for a 60% reduction in pain, many find that a very, very fair trade.
And okay, here's where it gets really interesting. Because if we want to conclusively answer our mission today, like, are polynucleotides a safe alternative? We can't just compare them to HRT.
No, we have to look at the broader landscape.
Exactly. We have to compare them to the other major non-hormonal treatment that cancer survivors have been pushed toward for, like, the last decade. And that is transvaginal lasers.
Yes, the energy-based devices,
Okay.
treatments like the Mona Lisa Touch or the Juliet fractional laser, these have become incredibly popular as a hormone-free way to stimulate vaginal tissue.
Because they sound incredibly precise, clean, and, I don't know, futuristic. A laser fixing your tissue. It sounds great.
It's good marketing.
But when you actually dive into the safety profiles and the sources, the contrast between lasers and polynucleotides is stark.
It really is night and day.
Let's look at the safety data directly. For polynucleotides, the sources indicate no known long-term risks.
No.
They are entirely hormone-free, they are biocompatible and strictly safe for cancer survivors. The side effects are basically entirely limited to the temporary, localized swelling from the physical needle injection itself.
Right. Now look at the data on transvaginal lasers. We examined the interventional procedure overview from NICE.
The National Institute for Health and Care Excellence in the UK.
Exactly. And while it's completely true that many studies do show a reduction in GSM symptoms for women using lasers, the safety warnings and reported adverse events are highly significant.
Yeah, the complications listed in the NICE database are intense. We're talking about burns,
Yes.
scarring,
Yes.
numbness, urinary tract infections, bladder pain.
And beyond just the burns, there are actually documented cases where the treatment didn't just fail to help, it actively made the condition much worse.
That's the scariest part.
The NICE overview details instances of de novo dyspareunia.
Meaning entirely new pelvic pain that wasn't even there before the treatment started.
Exactly. They actually highlight a very specific and frankly troubling case study.
What happened?
A patient presented with mild dyspareunia before undergoing laser treatment. She just wanted a little relief. But after 3 courses of the laser, her pain didn't improve. It became progressively worse.
Oh, no.
And 10 months post-treatment, she developed severe vestibular inflammation, and her pelvic floor had gone into hypertonus.
Hypertonus, meaning her pelvic floor muscles were basically locked in a constant, agonizing spasm.
Yes, essentially paralyzed in a state of cramping.
The irony here is wild. I mean, lasers sound like magic wands, right?
Yeah.
But the way fractional lasers actually work is by causing microtrauma.
That's the mechanism, yeah.
They literally burn microscopic holes in the tissue, basically relying on the heat to initiate a wound healing response. The body senses the burn, panics, and rushes new collagen to the area to heal the wound.
And that mechanism relies entirely on the body having enough cellular energy and reserves to actually mount a robust wound healing response in the first place.
Which is a huge assumption.
Exactly. Because if you are dealing with a highly atrophic, fragile, postmenopausal vagina, the tissue is already exhausted. Burning it to force it to heal is a massive gamble, which is exactly why we see these reports of severe scarring and locked pelvic muscles.
It's like trying to get an exhausted, starving factory worker to build more collagen by setting the factory on fire.
That's grim, but yeah, it's accurate.
While polynucleotides, on the other hand, just skip the trauma entirely. They don't burn anything. They just gently feed those exhausted cells the exact biochemical blueprint and the raw materials they need to heal on their own.
Which brings us back to the core mission of this deep dive today. This raises an important question, right? Based on the synthesized clinical guidelines, the safety databases, and the trial data, are polynucleotides a safe alternative to HRT?
And the verdict?
The evidence overwhelmingly points to yes. They offer this truly unique intersection of safety and efficacy.
Because they bypass the systemic risks.
Right. They bypass the systemic and psychological risks associated with hormonal therapies, making them uniquely suited for high-risk oncology patients. And simultaneously, they completely bypass the physical trauma and thermal risks associated with energy-based laser devices.
So they represent a purely regenerative biostimulatory approach.
Exactly.
So what does this all actually mean for you listening right now? Let's just distill the main takeaways from everything we've unpacked today.
Let's do it.
First and foremost, if you or someone you love is dealing with Genitourinary Syndrome of Menopause, you have to know that this is a massive issue affecting 80% of women.
You are not alone.
Right. It is not just normal aging that you have to quietly suffer through. The silence around this is doing real tangible harm.
Absolutely. Second, local hormone replacement therapy does remain the incredibly effective first-line standard of care for most women.
If it works for you, it works.
Right. But if you fall into that HRT gap where hormones are contraindicated, or, if you simply prefer a non-hormonal route, your options have evolved significantly. You no longer have to choose between suffering in silence or risking the thermal trauma of a laser treatment.
And finally, polynucleotides. Highly purified DNA from fish sperm. They are not science fiction. They offer a clinically backed, totally hormone-free way to regenerate intimate tissue from the inside out.
It's essentially handing your body the blueprint to rebuild itself.
With an excellent safety profile and minimal downtime, which is just incredible.
It is. And honestly, the implications here extend far beyond intimate health alone. It represents this fascinating evolution in how we view medicine, and I think it leaves us with a final thought to ponder.
Ooh, lay it on us.
For the entire history of modern medicine, our approach to aging has basically been compensatory. We have tried to fix the symptoms of aging by artificially replacing the hormones or the chemicals that eventually run out.
Right, pumping in outside supplies just to keep the factory running.
Precisely. But if we can now use specific purified DNA fragments to fundamentally trick our existing dormant tissue into acting young again, if we can feed it the raw materials to rebuild its own collagen and elasticity without introducing a single hormone, what other parts of the human aging process are we about to entirely rethink?
Wow. That is wild to think about. It changes the entire paradigm from managing decay to pure cellular reprogramming.
It really does.
Well, armed with this deep dive into the science, you are now in a much better position to have an informed, confident conversation with your doctor about what regenerative options might be right for you. Thanks for diving deep with us today.